Delightful to be here, and every time I come here to talk, I feel like I'm bringing coals to Newcastle because with the work that's being done here, you're obviously at the cutting edge of a lot of this work. And I think the issues that I'm going to talk about today are those that are impacting many people using psychology in clinical practice around the world. I want to thank you for the opportunity to be here again and present and focus on a very particular issue. I'm bringing you greetings from North Carolina. If you haven't been there, it's a state south of Washington, and it is about a 6-hour drive from Washington right here. And Durham, where I'm located, is about halfway across the state. And it's a beautiful state since we have the mountains called the Blue Ridge Mountains. I understand you have Blue Mountains, so get a chance to see those. And there's this incredible variety from the mountains to the sea. I'm at Duke University, which was formed by the Dukes, who were tycoons in the tobacco industry. North Carolina's a big tobacco area. And they wanted a university named after themselves. So in the neo-Gothic style, they made this university. And I've had the privilege of working there since 1978. And much of my work over the last 20 years has been research-focused, but I have been very active clinically in the past and more recently as well. Our research program, typically, the funding that we're able to get is to do work on disease-related pain conditions, pain related to cancer, pain related to arthritis. We do some work with other types of chronic pain conditions. And typically, we start out doing cross-sectional and longitudinal studies to try to understand how people adjust and cope with the pain that they have. And we then use that information to develop protocols to try to alter coping and appraisal processes to try to improve outcomes in pain in other areas. And our most recent work has really focused on developing novel ways to take these interventions and disseminate them into clinical practice settings so that the uptake will be much greater. And by the way, I did say 1978. I've actually been at Duke since 1978 and have been involved in helping many development of many multidisciplinary programs. And those of you who are a little bit younger than I might still be ringing, 1978, was there actually in 1978? And I always say, I was at Duke when the dinosaurs roamed the campus. So just to prove this, here's a picture of me on campus in 1978. So, psychosocial treatments for pain. I'm not going to talk a lot about what they are. I assume many of you have heard of them. Maybe you're using them in your own practice. I'm going to talk about some of the issues involved, but just as by way of quick overview, we now have, in addition to CBT, many other protocols for intervening psychosocially with patients or members of their social environment, things like mindfulness, acceptance and commitment therapy, emotional disclosure protocols. And we know that all these can actually alter the way people think about their pain, the way they judge their own abilities to deal with pain, and it can improve outcomes. And there are now systematic reviews and meta-analyses with a variety of pain conditions showing that these treatments, in fact, not only alter appraisal and coping, but improve outcomes such as pain, psychological distress, physical disability, medication intake, and so on. And the effect sizes are small to moderate, but it's clear that some patients benefit much more than others. And of course, one of the interesting areas for research is who benefits the most, and there's a lot of work going on in that area. So that's kind of a brief overview of where the field is. What's starting to happen so much around the world now are these treatments that were initially developed in settings very much like the one that Michael runs here. Specialized psychosocial pain treatment programs are now being translated into a variety of different settings. And this work started really years ago, 25, 30 years ago, with clinical innovators, people like Bill Fordyce and others, developing programs often on inpatient units or rehab units, and then moving from there to outpatient programs such as the one that Michael runs. Very experienced people running these things and having pretty good outcomes. The work then went to actually funded studies, randomized clinical trials to test the efficacy of these delivery of these conditions under somewhat ideal conditions and the kind of research conditions. And more recently, and the meta-analyses that I just showed you, those results are pretty much from those efficacy studies. More recently, the interest has been in conducting research evaluating the effectiveness of these programs. That is, in typical clinical settings where the treatment is delivered by people who already work in that setting, sometimes with relatively minimal training. And this whole thrust is to move us towards dissemination. And as we do this, certain issues arise. And one of the concerns that I have and others do as well, are we losing something in translation as we move towards further and further to the right in this dissemination trajectory? And let me just highlight some of the challenges, and then I hope to, by addressing the issue of fidelity and being faithful, to talk about how we might address some of these challenges. So one is, as this gets disseminated, these approaches are disseminated more, there's real changes in the patient populations that these techniques are being delivered to. So early on, these conditions were primarily developed and applied to patients who have what we might consider, I hate this word, non-malignant chronic pain. That is, pain that is not a marker in some way of disease activity. Most of the patients in these programs had constant daily pain. A major emphasis of these comprehensive pain programs are making sure the patients were appropriate, screening them to make sure they're disabled enough, they have enough pain, they're willing to engage with treatment. Patients with serious comorbid conditions were often ruled out of these special programs and so on. And what's happening now is these interventions are now being tested in much more varied populations. And many of the samples being studied in these newer studies and clinical settings often have multiple physical disorders. So I do work in a primary care clinic with minority patients, and I can pretty much tell you every patient referred to me is going to have chronic pain, probably going to have diabetes, hypertension, and they're going to be obese. Many of them will also be depressed. And if you work in primary care, this probably sounds very familiar. So we have patients now who are often more complex in terms of their medical condition than those seen initially. We also are finding a move into disease-related pain conditions. So many of the people that I now train are going out and working in cancer settings, for example, and much of their work is on cancer pain, cancer symptom management. Or they're working with rheumatologists, patients with arthritis. And they're also working with patients that are much more varied in terms of ethnic and racial background than is represented in some of these earlier programs. The other thing that we're seeing as this, it's sort of being a victim of success, as more and more people take this up, we see that people are using these techniques who have much more varied backgrounds and levels of experience. So many of these early studies that were done, and certainly many of the programs, are carried out by therapists who are very experienced, who've had lots of experience with chronic pain. Many of them were actually involved in developing the interventions, and they have an allegiance to those interventions. Many have worked for years in the intensive settings with difficult and patients with difficult and challenging chronic pain problems. Many of these individuals also felt very confident because of that experience they could actually deliver this treatment. They're familiar and they've contributed to the research and so on. What we're seeing more recently, if you're looking at some of the work in this area, there's much more reliance now on inexperienced therapists to deliver these types of interventions. There's a growing use even in research studies to have students delivering this treatment. So basically, people have a much lower level of experience with the pain conditions. Many lack the background and familiarity with the traditions and the literature in this area. And as a result of that, there are some significant gaps in their knowledge about how behavioral treatment is conducted. Also, having trained a lot of people who are not familiar with this, many are not very confident that they can actually deliver this. And many are not sure if it's going to work. They start to work with patients and they see improvements, and they're actually surprised themselves that it has an effect. So this is, I think, a natural sequence. As you get a treatment and it works and it gets disseminated out, these kinds of challenges arise. So along with this come changes in the quality of training. And what I want to do is talk about the importance today of being faithful, that is, fidelity to treatment, and how we can deal with some of these challenges of translating this by attending more to treatment fidelity. So basically, treatment fidelity refers to ensuring that an intervention is implemented with a patient as intended and is delivered in a comparable manner across all participants involved with that therapist. And one of the questions is, does this really matter? Well, what if you are not faithful? You know, there can be sort of undesired and unintended consequences, and a nice example of this from our country. You know, you can get a lot of heartbreak going on if you don't deliver, if you're not faithful to treatment. Now, what I often say is this particular issue, I'm a walker, so it's going to be really, I'm supposed to stay at this desk here, so I'm going to have trouble. You're going to find me keep moving out here. I often say this is an orphan issue. Many of you that work in medical settings, do research in medical interventions and surgical interventions, probably don't really think about this issue of fidelity that much. And that is because in drug studies, fidelity is pretty much there already. You have laboratories that, of course, initially develop the preparations that go into a medication. You have manufacturing centers where quality is monitored very closely, and so on and so forth. And in behavioral studies, you don't have that. In behavioral studies, a lot of the quality control and the fidelity of the intervention consists of working with people face to face and talking to them about what they're doing and reinforcing what they're doing. Now, when I talk to people about working on fidelity in their psychosocial interventions, these are some of the things that I hear. I often get looks that look like this, people folding their arms, kind of grimacing at me. And some people feel it's insulting to address this issue. And their attitude is, well, if you're going to train a nurse or a social worker or someone else to do this, just tell them to do it once or twice. They'll get it. You don't have to kind of work on really being sure they remain faithful. They will get it. Our therapists are experienced. Say we're doing this with a physical therapist. It's insulting. It's embarrassing to have to kind of work on this over time. Another is it's expensive. So, for example, I know of studies that looked at a psychosocial intervention where there was a plan built in to maintain fidelity to the treatment over time. About a third of the way through the study, the people running the study said, well, it's too expensive. We're going to drop that out. We're not going to include that anymore. And the people that were contracted to do the fidelity assessments, who were very well known at the Beck Institute, I don't know if you've ever heard of Beck's cognitive therapy, but it was basically the people that developed that therapy said, we no longer want our name on the study. And in fact, what happened was the treatment was not effective because the fidelity over time to the treatment declined. So yes, it can be expensive to do this, but without doing it, you can run into some real problems. So this raises the question, does it really matter? So let me go back to the drug study analogy. So let's say you are a medical researcher and you do drug studies, or you're certainly familiar with drug studies. Does fidelity to the drug treatment really matter? So what if I said to you, halfway through your drug study, the drug manufacturer has now moved to a very inexperienced site to save money. Okay, so you're going to be getting, you know, all the pills will look pretty much the same, but the drug is no longer being monitored. You have no idea what's going into that drug. And so the actual drug dose in your treatment arm may be higher or may be lower. And what about if the manufacturer says, well, you know, this is getting expensive, so I think we ought to put fewer pills in each bottle, and they can kind of deal with it on the other end. The patient can just skip a few days. Or I know what we can do. We can put other pills. We can mix those in with the real pills. Maybe they're even placebo pills, and they won't notice. You can only imagine in this situation there can be a lot of unintended consequences. So if we think it's important to attend to fidelity in our drug studies, that we want pure drug, we want to know what it is, we want to know the dose, we want to know it's delivered as intended, why don't we have the same level of concern with regard to a psychosocial intervention? Oh, this is the reason. Okay, so if you read many studies looking at psychosocial interventions, particularly some of the recent studies, you'll see a statement like this. Sounds great. All therapists attended a 2-day workshop and were verbally instructed in the intervention at the start of the study. Great. Everybody sits around the table, the verbal instructions are given, and they go on. So there are certain issues with verbal instructions, though. And to illustrate this, we're going to break you up into some groups here. And what's going to happen is I'm going to whisper a statement to the first person in your group. And that person will whisper the statement to the next person in the group, and so on and so forth. You can only say the statement to the next person next to you once. You can't write it down. You can't repeat it. You can't write it down. And then the last person in your group is going to come up to that board. Hopefully we have some pens. And you're going to write down what you were told. Now, bear with me. I'm a psychologist. I'm into role-playing, all this kind of stuff. So what it means is if it's not your group's turn, you can't look at the slide that I'm about to show up here. Okay? So this is group 1 right here. First 2 rows. Group 2 is the second 2 rows. Group 3 is everybody else. So I want the first person in group 1 to come up. Come on up here. Okay? And I'm going to get you to face towards me. I'm going to be facing away. Come over here. Okay, you stand right here and look at me. Don't look at the screen. I'm going to look at the screen. Okay? I know, it's really hard. Excellent. Okay, thank you so much. Okay, everybody else look away just for a moment. Okay? Okay. This is what you have to whisper. At the beginning and end of sessions, discuss home practice assignments. Remind patients to practice with relaxation geometry in the morning and coping statements and activity pacing in the evening. Okay?
Am I allowed to look?
No. Give it a shot. Give it a shot as much as you can. Okay. The first person in group 2. Come on up.
Can I pass it on now?
Yes. Yeah.
I'm ready to go.
You go ahead and pass it on. Do the best you can with it. Okay. Group 2. Same thing. Okay. Everybody in the back of the room, again, you're going to have to not look here. When you are nearing the completion of treatment, meet as a group, go over the handout that lists key points, and be sure to go into detail about what you have learned. Okay? Let's see, group 3. Who's the first person in group 3? It's these 2 others. I think it's you. Okay, same thing if you could stand there and look towards me. Okay, everybody look away for a moment if you would. Thank you. The study protocol for this study includes relaxation training, activity pacing, problem solving, imagery, and relapse prevention training. You can write it down, please. As soon as you make it all the way through, go up to the board. The last person goes up to the board. Okay, we have group 2 now. Very good.
Blame Milton. He never listens.
We're only for group 3. Who's whispering for group 3 right now? Okay. Just to speed up, why don't you write down what you've got at this point? Thank you. Okay, Michael, you want to wheel that out? If you could. And Michael, if you could read off group 1's statement, in case people can't see it.
Group 1 is, at the beginning of each patient, it is important to recommend.
Okay. At the beginning and end of sessions, discuss home practice assignments. Remind patients to practice and so forth. Okay.
At the end of the meeting, have a review.
Group 2, when you are nearing the completion of treatment, meet as a group to review things. That's okay. Go over the handout that lists key points. Group 3.
Group 3 was, part of the study is to focus on mindfulness and imagination.
This study involves relaxation training, activity pacing, problem solving, imagery, and relapse prevention. Okay. So my question is, how do verbal instructions hold up over time? Yeah, not too well. And that's a short time period. And this is the way the training is often done. If you were to come to a workshop to learn how to do these things, this would not be uncommon. I would get up and I would lecture at you. Maybe I'd actually let you see the slide, but I'd whip through and go to another slide. And I would hope that you would remember these things. I would expect you to remember them, of course. So you can imagine we've got this time zero. All therapists attended to a 1 or 2 day workshop and who instructed in the intervention. What do you think these sentences are going to look like a year later? Because often the same therapists carry out a program over time. And sometimes if you don't have somebody like Michael there kind of working with you, you're remote from the training site. Imagine 3 years later what might happen. So this brings up the problem, what's called therapist drift. So one of the things that happens over time, therapists give up or they change the treatment protocol. Maybe they can't remember it. Maybe they have other reasons they want to do this. And they start to do things a little bit differently. And one of the interesting questions, and this has been looked at in research, in what directions do people start to drift? So let me talk about some common types. So one is, if you're familiar with behavioral treatment at all, mindfulness and other things, you know it's very important what people do. And what tends to happen over time a lot with drift is people move away from, let's do some things together, let's focus on what you're doing at home, and more towards giving information, more lecturing, let me give you a handout. Another thing that people start to do over time is they don't focus on the homework. So again, go back to mindfulness training. If you've done any meditation, you know the key to it, you're supposed to practice at home. Okay? But sometimes, when you come in and you talk to someone, I'm going to get back here, it is uncomfortable to ask a patient about practice because maybe they haven't done the practice. And so people, well, we can kind of let that slide. And this goes along with this notion of protecting the patient. So some protocols, for pain management actually encourage patients to do things like exercise or set activity goals, things that actually will increase their pain or even increase their psychological distress, because that makes them more resilient. Over time, what happens with drift? Often people back off with that, even though that may be overcoming those obstacles, dealing with those tough situations might be the most important thing. And the other thing is people start to verge into other therapies they know about, they're more comfortable with over time. Now, one thing that can affect this is if you start to have the sense the patient's not motivated, you start labeling the patient in that way, you're probably more likely to drift in these directions. Certain emotional reactions can bring this up. So if you're feeling anxious or guilty or you're fearing, you're going to get a negative evaluation in the way you're doing this. You might drift off. If you're tired. And there are a lot of reasons it's important to do this in terms of improving the power of your study, reducing these unintended consequences, and helping subsequent people can actually replicate what you've done. Well, I do want to go back to this drift because it's sort of interesting. If you have a behaviorally trained therapist, if you think about the mental health area, people that do behavioral treatment, cognitive behavioral treatment, and they start to drift, what kind of therapy, we talk about these other types of therapies people might drift to, what type of therapy do you think they might drift into? Counseling. Okay. Which would be like what? Reflective listening. Chatting. Okay. And what if you have a therapist who's been trained more traditionally in counseling or psychodynamic therapy? Where do you think they tend to drift? And you're trying to get them to do this type of protocol.
Go back to what they used to.
Okay. Now, it's interesting. What happens with the behavioral people, like you suggest, they go in very much the more psychodynamic route and talking about the childhood and difficult conflicts, underlying conflicts. The psychodynamic therapists go more in the behavioral direction with advice giving and so on. So there are some predictable directions that people might drift, but the end result is unintended consequences. So what can we do to enhance treatment fidelity? And I'm going to just talk about a few approaches. We do know that there are best practices now. So if you're interested in this area, this is an article that appeared in Health Psychology that actually talked about best practices. And the literature does show if you adhere to some of these practices, your outcomes are actually better. And I think this is true not only for studies, but for clinical practice. So one is in designing your intervention. I think it's important to design it in a way that you can actually implement it, that it's not so complicated that people can't actually implement it as intended. I think it's very important to include training for fidelity as part of your ongoing work and also to evaluate that. So what do I mean by that? Well, one part of training is what we talked about initially, this sort of initial multi-day workshop. And that typically involves didactic training. So a very important component is having a treatment manual and having a conceptual model that underlies what you do with a patient. Because as you're working with a patient, all kinds of information is coming at you. You have to have a way to organize that information and reflect back on it. So in this didactic training, the best way to do it is to do a lot of modeling. So have an experienced therapist work with a role player and show how you might deliver various aspects. And the way we do this is usually very short, like a 5 or 10 minute modeling. And then we have people break up into pairs and do role playing with another individual in the group. One person plays the patient, the other person plays the therapist, and the group leaders rotate through these dyads and provide feedback. Then everybody comes back together as a group and they talk about what went well, what was easy for us to do, what was not so easy for us to do. And this 2 to 3 day workshop is not designed to provide the definitive training. It basically provides an overview of the skills that you want to teach somebody. Really, the mastery comes in the next phases, and that is most programs now are doing something called certification. And basically, what you do is you have somebody who's going to deliver this do an audio recording of a session, each session, in fact, of the protocol, with a role player. So they have a therapist who's going to deliver it, role player who's taught, here are some characteristics of patients with this condition, and they work on it as a dyad. It's audio tape, and then a supervisor listens to it and rates it for the quality. And if the person reaches a certain criterion, they're then okay to go ahead and do this. And then on top of that, there's ongoing supervision. And what happens is when someone sees a patient, the sessions are audio taped, a supervisor listens to those, and then comes together with all the therapists on a weekly basis and says, this is what I heard when I heard you working with a patient. This is what I heard that I thought was working really well. Here are things that you might work on. So a lot of what's happening in this group supervision is the consolidation. So you've learned some of the skills. Now you're actually applying them with the patient and consolidating them. So how do you evaluate treatment fidelity? Two ways. One is the person listening to those tapes each week is rating the tapes for what's called competence and treatment integrity. But you can also have independent supervisors rate them to make sure that they agree with this. So treatment integrity, you could kind of think of it as a checklist. Were the key things in the session done? Yes, no. They set the agenda at the beginning of the session. They provided a rationale for the use of a particular skill. They practiced the skill with the patient and so on. Treatment therapist competence gets into how well this is being delivered. So you could train somebody in relaxation with kind of a robotic voice, or you could use a much more relaxing voice and do this in a much more effective fashion. So fidelity really matters. Just by way of summary here, if you're faithful to the protocol, you're going to find that the outcome is much better than if you're not faithful. And there's evidence of this in trials with individuals and in trials with families of patients and so on. And you'll find that most programs now are making some effort to assess this and report this, but there's room to grow. So just by way of conclusion, we are moving with psychosocial treatments out into a broader array of environments. With this come challenges, and one of the biggest challenges is learning to deliver these treatments as they were intended. And by attending to the some of the principles of treatment fidelity, I think you not only improve the treatment for the patient, but I think you can have a better outcome for your programs in general. So I will stop there and address any questions that you might have about this area.